Yep, we can hear you.
Hi, everyone.
Is that you, Lisa?
Yep.
Good afternoon, everyone. Thank you for joining today's learning community session on trauma-informed care across the Intercepts. This learning community is for Justice and Mental Health Collaboration Program grantees. It's being hosted by the Training and Technical Assistance Provider, the Council of State Governments Justice Center, and is funded through the Bureau of Justice Assistance. We're very excited to hold this third session in partnership with the Policy Research Associates. Just as a reminder, these sessions are being recorded, although our faces will not be captured in the recording. And just as a reminder, you can mute yourselves at this time. Next slide, please. So here is a brief agenda for our third session together. We'll start with introductions, then move into the content for today's session, where we'll have Dr. Callahan and Magdalena Morales provide information on trauma-informed care, specifically in Intercepts 4 and 5. Then we'll have a discussion period where you can ask questions on the presentations provided. As usual, we like the sessions to be really interactive. So feel free during that discussion period to unmute yourself, or you can type into the chat box, and you can, it's always great to hear how the content relates to the work you're doing. It's great to hear any questions that you have, any challenges you're facing, or successes that you've had. And lastly, we'll talk about exercise 3 and how your grantee teams are thinking about implementing the policy or practice you revised for exercise 2. And lastly, we'll wrap up and discuss the last session, which will be held on September 30th. Next slide, please. So now we will have today's facilitators just tell you a little bit more about ourselves. So Magdalena, if you'd like to start.
Yes, good morning and good afternoon. I'm in Mountain Time, so I know some folks are in different time zones. First of all, I want to thank you for the work that you do. I know how important this work is, especially now in the climate that we're currently in. And trauma-informed care is really the key to being successful in whatever role we play in working with justice-involved individuals. I do trauma training for the GAIN Center. And something that I want to do is just read the definitions. There's different definitions about trauma. So what I'll do is I'll talk about trauma and how it impacts people that we work with. I've been a probation officer for about 17 years. And in 2011, I was promoted and appointed as the Chief Probation Officer in El Paso. I'm a licensed therapist, I'm a mental health advocate, I'm a social justice advocate, and I'm happy and proud to be here today. Thank you.
Hello, everybody. This is Lisa Callahan. I've introduced myself to you a couple of times, so I will just say I'm happy to be here, and I'm looking forward to hearing what I call her Maggie Morales, is going to talk about the work that they've been doing in El Paso, and looking forward to the discussion.
Hi, everyone. Welcome. Ethan Kelly, Senior Policy Analyst with Behavioral Health Division at the Council of State Governments, and happy to see everybody on our third session.
Hi, everyone. My name is Rachel Lee. I'm a Policy Analyst at the Council of State Governments Justice Center. Also happy to be joining all of you again for the session today. And I think I work with some of you specifically as a TA coach with different JMHCP grantees.
And hello, everyone. I'm Allison Upton. I'm a project manager, colleagues with Ethan and Rachel at the Council of State Governments Justice Center, and also excited to be in the session today and looking forward to hearing more discussion on Intercepts 4 and 5.
Great, thank you all. If you could just turn to the next slide, Allison. Thank you. So just to recap, overall, the goal for this learning community has been to have grantees identify opportunities to implement trauma-informed care across the sequential Intercept model. And so in the first session, as you all remember, we took a deeper dive into the opportunities specific to Intercepts 0 and 1. And then last session, we looked at more closely at Intercepts 2 and 3. And then today, we're looking specifically at Intercepts 4 and 5, which encompass Reentry and Community Corrections. And then just looking forward, you'll see that we have our fourth session, which will be a follow-up meeting on September 30th to talk more about the successes and challenges people are having in terms of implementing trauma-informed care policies and practices, and to foster the peer learning component as you all move forward with your work. Next slide. Great, so now we'd love to do a quick roll call to just hear who's on the line today. So if we could have one member for each grantee team, just let us know who else is joining the call, if you have other team members on the line, and their roles. So we can start off with Chatham County.
Hi, I'm Charity Collier. I am down in Savannah, Georgia, in Chatham County. I am the project coordinator for our Stepping Up initiative down here, and I believe I am the only one on my team today.
Okay, great. Well, thank you. Next, we have City of Lubbock in Texas. Okay. If you're speaking, we can't hear you, but you can also feel free to type in the chat box if you can't, if your microphone is not available. And then I don't believe we have anyone on today from the Colorado Division of Criminal Justice, but I'll just ask if anyone from that team was able to join. Okay. I don't think anyone's on from that team. Next slide, please. Okay, is anyone here from Fort Bend County?
Hi all, this is Nima Ganga. I'm the project manager for the Stepping Up program for Bend County, and Faye James is also joining us today.
Great, thank you. And Faye, and what is your role in for the grant?
Sorry, I was taking a second to find the unmute button. I am just assisting currently in the grant. I'm looking to be moving into the navigator position when that comes available after we finish our planning process.
Great, thank you. We'll move next to Kanatsai Indian Tribe. Okay, I don't think there's anyone on. How about LaForge Parish Sheriff's Office? Okay, I don't hear anyone from LaForge. How about McLean County?
Hi everyone, Danelle Pressburger here from the Center for Youth and Family Solutions. My role is CAT coordinator, or also known as wraparound coordinator. And I believe Corey might be with us as well.
Yeah, I'm on.
Great, thank you both. Next, Mental Health and Recovery Services Board of Union County.
Hello, this is Mackenzie Poling. I'm with the Mental Health Board. I serve as the project coordinator for the grant.
Thank you. Next slide. Great. And do we have anyone on from Omaha Police Department?
Deputy Chief Michelle Bang and Officer Lee Colfer.
Very glad to have you back on. And then I don't think we have anyone on from Pima County. So anyone from Rockingham?
Yes, ma'am. Charles Prater and Denise Janoka are listening in as well.
Great. Thank you. How about Sacramento? Okay, not sure I hear anyone from Sacramento on the line. How about town of Tewksbury in Massachusetts?
Hi, Matthew Page Shelton here, Regional Director, and I'm also on with Maria Rogerio, my Prevention Director.
Wonderful, thank you. Well, it's great to have everyone on the line. If we could go to the next slide, please. Great, and now I'll turn it over to Dr. Callahan to tell us a little bit more about trauma-informed care and Intercepts 4 and 5.
Okay, thank you, Rachel. Next slide, please. There we go. As we've been working our way across the SIM or across the sequential intercept model, we've been focusing on 2 intercepts at a time. As the overview, we did 0, 1, 2, 3, and today we're working on 4, 5. But one of the reasons why each time we start another focus, we present the full SIM model is to show that it really is, it is a model, and each of the intercepts are connected either directly in time, but connect back to earlier intercepts. And I think that with Intercepts 4 and 5, when you're talking about reentry and community corrections, those areas probably have the most contact with the earlier intercepts of any of the other intercepts. Probation works with police, with crisis services, certainly with the jail and with the courts. So it's those who work in other intercepts probably, if you don't work in 4-5, you probably work with 4-5 quite a bit. So much of what we're going to talk about today and what Maggie Morales is going to talk about really should resonate across all of the intercepts, even if it isn't directly where you are working. Next slide, please. So Intercept 4 is reentry, and I will throw myself a little bit under the bus here and say, I've been working in the field of criminal justice for a long time, 35 or more years, and it's only been in the last 15 or so years where people really even use the term reentry. It always existed, but usually reentry was you got a bus token or a subway token, depending upon where you lived. If you were discharged from jail or prison, given back your belongings, and sort of the door opened and you were sent out. That was what reentry was. And so it currently, and in today's world, it's become much more of a concentration, because we've learned that if you don't do reentry well, recidivism is inevitable. And so as with other parts of planning, and that we've talked about in the earlier intercepts, it's really important to think about ways that your reentry process can become more trauma informed as well. It isn't just a given that it would be. Next slide, please. I think all of us have read figures, maybe in your local newspaper or national newspapers, especially with the opioid crisis and the number of overdose deaths. Ooh, okay. But really, reentry is a matter of life and death. We know that the first few weeks when someone is discharged, especially from state prison, but also from jail, is a really very dangerous time for them, not just to recidivate, but also to lose their lives. The death rate is 3.5 times higher for people released from prison. And the likelihood of dying, for example, from a drug overdose is really astronomically higher for people leaving jail. And I mean, there's some very practical reasons for that. There's some medical reasons for that, not the least of which is if someone has been in prison and jail, while we know there are illicit substances in jail and prison, that's not the general, that's not the general population isn't using. So when they are discharged to the community, they may be inclined or tempted to reuse. And in many cases, they've detoxed over their period of time of incarceration. And so the risk to fatality is quite high. They may use at the same level they did when they went into jail or prison. And if they've detoxed, then they certainly are more at risk of overdosing if they pick up where they left off when they went in. In fact, overdose death is the primary cause of early death from people once they're discharged from prison and jail. Other causes of death are what they are in the general population. Perhaps higher with the offending population would be homicide and suicide, but other kinds of health-related causes of death as well. Next slide, please. So reentry, as I said, is more than just giving someone a bus token and their belongings. It really should involve for reentry to be effective, that means in not just preventing recidivism, but also helping people recover and reestablish themselves in their communities and with their support systems. But there needs to be an effective and evidence-based risk needs assessment done. Not everybody needs the same level of supervision. Not everybody has the same high needs, for example. We know that people who have substance use disorders and people who have mental illnesses have very high needs when they are released back into their communities. And so doing a comprehensive risk needs assessment is really a critical key to effective reentry. They should have a treatment plan that addresses those risks and needs, and making sure that before the person is released, making sure that whoever's going to be their community-based provider not only has been identified, but there's been some connection made, and that there's coordination and planning and implementation of their reentry plan. A common phrase is reentry planning begins on the first day when someone is admitted to jail or prison, because it is a complicated process, and one, when done well, can be very successful. Next slide, please. It's not necessarily an easy lift to do effective reentry. Sometimes, especially in jails and, well, in prisons too, you don't always know when someone's going to be discharged. Right now, during the COVID era, people are being discharged very rapidly, and sometimes complete discharge planning or complete reentry planning just isn't even possible. Someone's gone before their case manager or reentry specialist has been able to really develop a comprehensive plan. Many communities don't have sufficient community-based supports. It's also, I would add an asterisk to this as well. Many of the community-based supports that you had in place in January right now are operating on a remote or a very limited basis. So the way in which even those community supports are connecting with individuals coming out of jail and prison are different because of COVID. Same thing with employment. There are many obstacles to employment for people who are have a criminal justice history. Housing is very difficult for people to obtain safe housing, housing that meets the criteria of their discharge or reentry plan also is very difficult to meet. It gets increasingly harder. It is probably one of the least resourced areas in the area in criminal justice. I'd add an asterisk here too. It's beyond the scope of this webinar, but there are some resources that specifically talk about overcoming some of the legal barriers that you may be facing, especially with individuals who you're trying to find housing, follow discharge from jail or prison, especially if they have a substance use, a developmental disability, or mental illness. There may be caveats to some of the restrictions that that are there just for generally across the board for justice involved people. So it's really worth pursuing someone who is a specialist in housing to see if there may be exceptions under the Americans with Disabilities Act to see whether there are caveats for people who have mental illness or substance use or developmental disability. So I'd really encourage you to not just assume if people you're working with, because they have a justice involvement, that they're precluded from living in, say, public housing, because the Americans with Disabilities Act really does supersede many of those restrictions, and it's worth pursuing that. We know that when people go to jail or prison, and I would add especially people who have behavioral health problems, have often burned every bridge before they're doing this latest tour of duty in jail or prison. So reinstating or making new connections to families and to family members and support is really important. Sometimes it's exactly those friends and family who they're not allowed to see because of perhaps they also are involved in the justice system. Gaps in connection to treatment is really a critical issue with people with substance use and mental health disorders. Connected to that is delays in getting medication. Some states have medication grants where someone gets, say, 30 days of medication of their psychiatric medications, for example, upon discharge, so they can connect up with their provider and make sure that they have an appointment to get their medication renewed, and so there's no gap and there's no really disruption in their treatment. Next slide, please. So how can you make trauma-informed adaptations to your reentry planning? It should be part of your risk needs assessment. Doing a thorough risk needs assessment should also take into account someone's trauma history and their trauma symptoms. We know that people who have trauma histories, when they are triggered, and many people when they go back out into the community are faced with some of the triggers that they were encountering before their last arrest or the most recent arrest. It's really important to make sure that trauma assessment is done as part of the discharge planning, because they may be going back into the same communities, the same housing, with the same people who were in fact associated with some of their trauma. And so we know that being triggered with trauma can also lead to substance abuse relapse. So it's important to make sure that that's part of the needs assessment, and make sure that you have plans for people who you've been working with around their trauma, whether it's through groups or individual counseling when they're incarcerated, making sure that treatment that you're providing for them, those groups that you're providing for them, that they have a place in the community that they can immediately connect with, so that they can continue that work as well. Make sure to include the person in their planning. They would be able to tell you about perhaps what part of their life before, what part of their life they don't want to discontinue. It may be someone who would be a natural person with whom they would connect. That may not be someone who would be a healthy connection for them. It may be someone who in fact was part of their, was traumatized them during the course of their life, and going back to live with him or her perhaps would not be wise, wouldn't be healthy, wouldn't be safe. And so you should always include the individual in his or her planning and ask them what would be a safe environment as far as they're concerned to live in. It may not be obvious to us, but it's certainly, they could reveal that to you, where they would feel safe living. Making sure to connect with the providers, that includes trauma-informed, evidence-based trauma-informed providers, and make sure that you include, as part of that, as a warm handoff. Some jails and prisons allow for in-reach before someone is discharged. There are some programs, for example, some mental health courts allow, if someone has, for example, a jail sanction, if they've accumulated enough violations as part of their probation or part of their mental health court conditions, they allow them to stay in contact with their community-based case manager, even though they may be serving a jail sanction. So it's really important to make sure that there's a warm handoff between the jail and the community provider in order for it to be a more trauma-informed approach toward reentry. Next slide, please. I mentioned housing before. It's for people who have trauma histories, making sure that they have safe housing that they feel safe in, that meets your criteria for discharge, is really important. And I would also say at this point, sometimes we've had to, I've spoken with judges who have had to intervene with regard to some of the community-based programs and the housing, because it it may not have seemed obvious to the individuals doing the planning that this was really a place where the person was likely to be re-traumatized. For example, one of the judges in New York City, her courts are very trauma informed. In her veterans treatment court, the group that provided trauma group therapy to people in the community generally had co-ed groups. And she knew from her work with her veterans treatment court that wasn't a trauma-informed approach. And so she would not send her veterans in her veterans treatment court to that group counseling, even though it was labeled as trauma counseling, because she didn't think that it should be men and women in those trauma groups together. For both the sake of the men and the sake of the women. It wasn't just to protect women, it was to protect the men as well. So the more your judges know about the programs that are associated with your reentry and other probation programs that you have, they can serve as an advocate. And most people listen to judges. And when the judges put their foot down and say they're no longer going to send someone to a particular program because it doesn't meet their criteria, it usually sways a little more influence than most other people in the justice system. You want to make sure that you reactivate benefits prior to release. That covers not only health insurance, but other kinds of insurances. It could be SSDI, for example, not just Medicaid, but also SSI and SSDI. There are programs that can train people in your jail. It's called SOAR, S-O-A-R. It's an acronym, and it trains people to around benefits and making sure people, as part of their reentry plan, that they've been reconnected to their benefits. It's also important for your judge to know, for example, and others who would have some control over the length of time someone may have, for example, a probation violation or a violation of a treatment court. It's important to know whether or not your state is puts the benefits on pause when someone is in jail for less than 30 days, or whether it's a suspension state. And if you are a suspension state, I would start talking with some of your legislators to have it become just a state that puts those benefits on pause. So the minute that you would release somebody back into the community, their benefits would start right back up again instead of having to reapply all over again. Now for state prison, that obviously doesn't matter because they're in for longer than 30 days, but it's a real issue for people who go to jail. And thinking about the way in which how long you craft sanctions for, it's important to know at what point in time do those benefits stop for people who that perhaps a 30-day sanction could instead be a 27-day sanction. You could get the same benefit in terms of the violation, but the person wouldn't lose their benefits when they're released. So knowing that and knowing how important continuity of treatment is really a very important adaptation to make as in your reentry program. I talked earlier about providing medication to people as they leave so that they don't relapse, both in terms of, for example, MAT, but also psychiatric medications and other kinds of medical medications that they need. If they're feeling really bad because they haven't had their high blood pressure medication, or they haven't been able to get insulin, they just feel medically unhealthy, and it's a risk factor for their relapsing in terms of offending or reusing illicit drugs. Lastly, talking about within your reentry programs, having specialized supervision, having someone a group of people who are specially trained to work with people with behavioral health disorders, mental illness, substance use, and trauma histories, can really not only provide better, more trauma-informed supervision for the people who are under supervision, but can also move individuals that are very high needs off the caseload for other probation officers who certainly have the skill set to address the needs, but would perhaps have a higher number of people under supervision if they didn't have the high risk, high need people that you would have with people with behavioral health disorder. Next slide, please. There's the Gaines Center reentry checklist. These are the domains that are covered It's available. I believe this is a hot link on the slide. So if you download the slide, it will take you right to the reentry checklist. And these are all the areas that the checklist has you address with the individual, not without them, but with them, in terms of making sure all of these areas are covered. I'm not going to go through all of them, but you can go to the Gaines checklist and see the kinds of questions that are asked, and it gives you the opportunity to see all of the areas that they're going to need help with, and areas where they don't need help with it. They already have that in place before you meet with them. Next slide, please. So back to the sequential intercept model. The last arrow here is pointing at Intercept 5, and this is community corrections. This is probation and parole. Just again to show you where we are across the SIM and how each of these really build upon what's gone before. Next slide, please. So Intercept 5, community corrections and community supports. Next slide, please. This is a staggering number in my mind, and one that has been growing consistently over the last number of decades, certainly since the 1990s. There are approximately 7 million people under correctional supervision in the United States, far more than any other country in the world. The majority of people are on probation, another 12% are on parole, so they're in our communities. Only about a third of people under correctional supervision are in prison and jail. And I think most of us think about corrections, we think about that third, not the 2/3 of people who are living in our communities. We would like them to live safely and healthfully in our communities. We don't want their lives to be disrupted again, and we want them to not recidivate. We want them to reclaim their lives and work on their recovery. And it's important to remind people that pretty much everybody who goes to prison and jail, certainly everybody who goes to jail, unless they die when they're in jail, is going to be released on probation. And most people who go to prison are going to be released on parole. Very few people live out their entire lives incarcerated. So most people will at one point or another be released and will be under some kind of community supervision. Next slide, please. There are lots of barriers in community corrections, and this isn't to say that these aren't necessary. I'm not at all suggesting that all of the things that probation and parole require of the people under their supervision, I'm not suggesting that they're not necessary. But to be trauma informed, and we'll dig a little deeper into this in a minute, really has us considering everything we do as part of community corrections. It's also assuming, going back to that first point, doing really good risk needs assessment. Not everybody needs the same frequency of meetings. Not everybody needs the same number of check-ins. Not everybody needs the same frequency of substance use testing. That's part of the reentry planning. And how people are the day that you release them on probation or parole isn't the same way they're going to be in 3 months. They may be at higher risk because of the people they're hanging out with, or they may be at lower risk because they are firmly in a healthy relationship, they have a job, they've regained custody or visitation with their children, etc. So this is, their risk and their needs is not a fixed point in the moment you send them out into the community. It's something that needs to be assessed and reassessed on a regular basis. And all of these, because the risk and needs are fluid, and the level of supervision, the intensity of the probation and parole should reflect that, not just a one-size-fits-all. There are never enough mental health services for people who are in community corrections. There aren't enough mental health services for people who are not justice involved. So it's really important to advocate to have adequate, I would say more than adequate, to have sufficient mental health services. It's important that if you have people you're working with who you know have significant trauma histories, and perhaps were working on their trauma when they were incarcerated, and as part of their reentry plan, you want them to focus on this, you're going to need to hook them up with providers who are in fact trauma informed. Again, this can be something that your supervisor can insist on, whether it's the judge or whether it's your director of probation or parole, to insist that those providers that you're going to be working with, that you're going to be providing them customers basically, are in fact trauma informed. It's important to consider the support system the person has and whether in fact they have any support system. For many people, their support system was the people who they got in trouble with. And same thing can be said for their family. So it's really important that they have a support system in place. It may not be who it was when they were incarcerated, but they will have to have a support system in place for them to be successful in the community. And also it's important to use a trauma-informed lens in terms of your probation hearing violations. And Maggie will probably talk about this to a greater extent. Next slide, please. Some trauma-informed adaptations. Be flexible when you can. You know, use graduated sanctions. Take into account why someone may be relapsed or why someone may be recidivated. Were they triggered? Were they sent into a situation, a housing situation that was just catastrophic for them in terms of their trauma history? It doesn't mean that they won't have a consequence, but use a trauma lens in trying to understand why someone perhaps used substances again. We know that there's a very strong relationship between trauma and substance use. So having your trauma-informed lens on can help you at least ask the questions of what happened that led you to relapse and use again, or to not take your psychiatric medications again. Making sure that your staff are fully trained on trauma and the importance of being trauma-informed. Make sure, again here, use the individual in their planning. Don't tell them what they're going to do. Find out what they can do within the range of what they have to do. And it may be simply a matter of, I would say someone has to get her children on the bus at 8:45. In the time of COVID, who knows if children are getting on the bus? They may be trying to do homeschooling over the next 2 or 3 months. And that will be a challenge. That's a challenge for people who are not justice involved. Include their wellness, not just their behavior, but their wellness in the planning, and make sure that you communicate clearly with the client on a level that they understand. And this isn't to say that they aren't smart. It may be that their understanding of what you know is limited. It may be the first time they've been on probation. So it's important to be really clear when you communicate with the client about the terms of their community corrections. Next slide, please. Make sure that treatment providers are part of your supervision team. Make sure those treatment providers are trauma informed. Work with advocates, housing advocates in your community. Talked about reactivating benefits already. That will really, really help people stay on their treatment plan if they have access to their medications. And make sure, again, revisiting having specialized supervision. Next slide, please. I'm going to turn the microphone over to Maggie Morales, and I will mute myself and look forward to hearing from you at the end of Maggie's presentation.
Thank you, Dr. Callahan. So in Paso County, Texas, for those of you who aren't familiar, we're right on the border, on the New Mexico border, as well as Mexico border. We have a very large military base, which is Fort Bliss. So we're very rich in culture, traditional culture in the Mexican American population, but we've also, since the base realignment and closure, have now expanded to having different, very rich in culture from other parts of the country and other parts of the world. Being trauma informed was a priority for El Paso, and I'll tell you a little bit of the history. So I met Dr. Callahan several years ago when we were a grantee. And at that time, everything that could go wrong with our grant was going wrong as far as access to care. For those of you who aren't familiar, Texas is not a Medicaid expansion state. So we relied heavily on the assistance of our community partners. And at that time, there wasn't a lot of services that were available to help us with our justice involved individuals. At that time, there was a lot of transition going on within our community in regards to the types of programming that was available. The state had several cuts, and truly, Texas was not trauma informed. So it was very difficult to meet the objectives that were expected at the state level and of our governing body. and tried to do the best that we could in providing services for our folks who were justice involved and had, was one of many myriad of issues that they have. And it came about when we wrote this grant about collaboration. That's when we truly brought the stakeholders to our community to the table. And the sequential intercept map was, I think, one of the biggest eye-openers for our local leaders, our legislators, the sheriff's department. We had several judges just to see the gaps that existed within our community. We're not a large urban city. We're not Houston, but we're one of the top 10. So even though we had services available, we weren't linking. So Dr. Callahan talked earlier about warm handoffs, and that was something that was missing. That was the gap, is that folks were engaging in a revolving door, as we would say, whether it be with jail or prison or violations, because the extension of continuity of care was not being provided. So who involved in its implementation and sustainability? Well, that came down to the probation department. We provided and we secured the grant, but it was our role to make sure that we brought the stakeholders to the table. And it was funny at that time because it was really having to market. Change is tough, but like Dr. Callahan said earlier, you know, people tend to listen to what judges have to say. What I did at that time is I found champions. I found champions in the judiciary who believed in what they were doing, who believed in our community, but more importantly, believed in our department and what we were wanting to do to provide more effective services for our justice-involved individuals. Not just folks who have behavioral health conditions, but people in general who were just falling through the gaps and ending up in jail and in prison. And at that time in Texas, we had a high revocation rate. For those of you who are not familiar with, I didn't see many probation departments. Revocation rates are people who are placed on community supervision, probation, who violate terms and conditions of probation and go to prison. The issue was that many of the violations were not necessarily new offenses. They were what's called technical violations, and that's somebody who failed to show up for a report, somebody who failed to show up for a treatment appointment, somebody who failed to show up for any number of items that are outlined on the terms and conditions that I'll cover in a little bit. So we had to figure out, what can we do to mitigate this? How can we keep, one, our community safe, two, make sure that we provide the services that we need to provide to ensure that the clients that the judiciary are entrusting to us are successful. And it really boiled down to what Dr. Callahan talked about was, you know, implementing risk and needs. At that time, Texas was shifting, and we had adopted what is known as the Ohio Risk Assessment. We did the testing, and one of our chiefs from one of the larger counties actually helped create with Ohio the Texas Risk Assessment, which is a standard across the state for all probation departments. We're required to have a risk and needs assessment that's validated to ensure that we can develop treatment plans and supervision plans that are consistent with the needs of the individual and not just a cookie cutter approach. How has it affected outcomes, staff, and community? We've had very positive outcomes. I was contacted by an organization that was wondering how El Paso had reduced its revocation rate and why we had high numbers of success. And a lot of it had to do with being trauma-informed. I'm a trauma-informed provider for the Gain Center for SAMHSA, so that is my passion. And for those of you who have had the benefit of viewing the video, I'm actually in the video because of making sure that I spoke out when I watched the first one, and we talked about inclusivity. And that's something that we had to be very mindful of, making sure that everybody that needed to be at the table was at the table. Like I said, from law enforcement to the local mental health authority to a person who was representing a population that was underserved, you know, the LGBTQ population, or folks who just language barrier issues. So everybody that needed to come to the table was invited and was welcomed. What are some specific examples of trauma-informed practice and policies in El Paso at Intercepts 4 and 5 is that, next slide, please. You know, I'll talk about that by giving you a brief history. So historically, courts and criminal justice systems used a one-size-fits-all approach at the different points in the criminal case process, which means that everybody was treated the same. Once somebody was arrested and went through a criminal justice process, as an alternative to sentencing and sending somebody to prison, what happened was that people were given terms and conditions, standard, regardless of the needs, regardless of the individual, regardless of the homeless status, regardless of a person's level or ability to adhere to those conditions. And by the way, that's our beautiful courthouse that I wanted to showcase. Next slide, please. So the more progressive in researching, I'm at that time I was a younger chief, and to me, it was important that in order for us to make change, we had to have something that validated what we already knew to be true. And what I mean by that is that we knew that there was something missing. We knew that there were gaps. So I needed to find some kind of research, something that said, this is what needs to get done. And that's how people listen. And that's why evidence-based practices are so effective, because it's been proven to show success. And that was one of the ways that I got people on board. You know, and Dr. Callahan chuckled when I would tell her that the champions that I found were two judges who were specialty court judges. And I knew that their heart was in it. I knew that, you know, their work ethic was impeccable, but more importantly, that they were very passionate about what they've done. One of our courts is a national training court for DWI, and the other court has a specialty court to include competency restoration and substance use disorders. So they're very successful courts, and I knew, like the judge that Dr. Callahan talked about, they knew trauma, they knew the principles of trauma, and they knew what effective programming meant. So we began the process of meeting every week on Thursdays, and I had them sign in, and we went through the objectives of what we needed to do. And we really conducted an assessment of the services that we have, identified the gaps, and then we implemented, and we, using the National Institute of Corrections model, you know, we knew that we had to use evidence-based principles. Something, interventions or programming that were promising or have been shown to be effective in working with individuals who were justice involved. Organizational development, that was one of the biggest challenges. Again, this is Texas, we have a certain mindset, but more importantly, we had at that time, our staffing table was officers who had been here for 15, 20, 30 years, that what we used to call old school mindset about the tail 'em, jail 'em, and nail 'em, which means that we're here and as a diversion from prison, but that's ultimately the goal. So when we came in, we changed the focus and, more importantly, the responsibilities of what our probation officers' role and responsibility was in the supervision of our clients. And that was part of becoming trauma-informed care. And what I did is, at the time, is I became certified in training, and we ended up training my entire staff from the front door, which were our receptionists who would greet at the time when we still had face-to-face clients coming in, to, you know, the counselors, the probation officers, the court coordinators, and the specialty court staff. And it was important that everybody be on the same page. It was very rewarding at the end to see the shift in mindset. And folks that were very traditional in what they believed to be criminal justice system or probation, you know, understood. It was tough. We had resistance, and let me tell you, change is not easy. But when we are confident and committed to making a change in how we treat people, we see the benefits. Collaboration, that was the key. When we did the sequential intercept mapping back in 2014, it was a rude awakening. It was a huge eye-opener. And even at the time, there were some leaders who rejected some of the findings that we had, because we had to admit to ourselves that was us. It was our agencies that were inadequate in providing certain services. So it took some time, you know, what we called it the storming, forming, and norming. And it was something that needed to happen in order for us to get to a place where there was respect for each other, but more importantly, that we treated everybody, whether they were in custody, whether they were on probation, whether they were in court, whether they were homeless, whether they had money or not, with dignity and respect. And that's where it began. And that's the root of trauma-informed care, is treating people with dignity and respect. You know, what people need when their justice is involved, and this is I'm taking from our trauma-informed care training, is RISC, which is the acronym, which is respect, information, safety, and choice. When we implement those principles, it significantly reduces risk, which is the risk and need to reoffend or to recidivate. Next slide, please. So El Paso County Community Supervision and Corrections Department. I know it's a mouthful. The core mission for the CSCD is to promote public safety and to reduce recidivism through the expanded use of the evidence-based supervision practices. Dr. Callahan talked about specialty programs. So we have numerous specialty population services, and we have specialized units. And again, all of that is based on an assessment, the Texas Risk Assessment, that develops the level of need. We design a template, we design a case plan based on the needs of the individual, not based on they have to fit into that program. So what we've done at that time is we created mental health, behavioral health units. We created even changing names that can cause, or would, like Dr. Callahan said, can trigger. You know, we used to have a caseload that was called the child abuse unit. Imagine being placed in a program that's called the child abuse unit. So we changed it to family preservation. And now it's one of our more popular programs because we partner with the local child protective services. So this is where we work with our community to be able to facilitate services. And the kind of what's in it for me is we help folks who work in these other programs and our stakeholders and our partners to ensure compliance or adherence to their treatment plan, their supervision plan, or their monitoring plan if it's a caseworker with one of the local services that provide supervision for people who have CPS cases, Child Protective Services. The risk need responsivity model, that is critical. We have people who believe that because folks are justice involved, they're going to be told what to do. That's where the responsivity comes. Dr. Callahan did a fantastic job in covering risk and need, so I'm just gonna kind of glass over them. It's basically saying we assess the level of risk when it comes to criminogenic, we identify the need and hopefully coordinate. For those of you who are fortunate enough to have expanded care, Medicaid expansion in your communities, that's fantastic because there's a method of payment. In Texas, we don't have that. So again, relying heavily and cultivating those relationships with our community-based partners has been critical. The responsivity is the key. This is where being trauma-informed is critical because responsivity is in the language, in the model, in the, even down to somebody's personality, if those are a good fit. Now imagine yourself going to a doctor who you just don't get along with. You have differences in opinions or just simply something doesn't jive. How effective is the treatment going to be? And that's kind of what I talk about when we did some of the training. So making sure that the responsivity, the person that's providing the services fits in, that there's a good match with folks, whether it be when it comes to language, whether it be learning abilities, whether it be accessibility. Right now during COVID, it's very difficult for justice involved individuals who have serious and persistent mental illnesses because a lot of the services are still doing telehealth or telework. Well, you know, a lot of the folks who have serious and persistent mental illnesses who happen to be homeless or who are, you know, couch surfing don't necessarily have smartphones. They don't necessarily have the necessary equipment to access those services. So there still is a gap, and those are the challenges. So it's anytime that something changes, we have to adjust our model. Trauma-informed and culturally competent programs and services is something that we as a CSCD can provide, because part of what we do with that is making sure that our officers understand the role that they play, that we're no longer enforcers, that we're no longer what we would call a compliance officer. We're agents of change. And part of how we treat people with dignity and respect, using the universal assumptions of trauma, is important. If we treat everybody as if they've had experienced trauma, we don't have to worry about re-traumatizing folks who have been traumatized. So for the purposes of this, I want to read the Sampson's definition of what trauma is, because many people have different types of I guess, understanding what trauma is. But when it comes to justice-involved individuals, you know, Sampson's definition of trauma is an individual trauma results from an event, a series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or threatening, and that has lasting adverse effects on the individual's functioning and physical, social, emotional, or spiritual well-being. So it's the 3 E's: the event, the experience, and the effect. So Dr. Callahan earlier mentioned about sometimes when it comes to reentry, when our folks are sentenced and they're not going to jail or they're not doing prison time, but they're placed on some type of community supervision, whether it be probation or parole, many times they've already had severed ties with family members because either the substance use disorder or the co-occurring disorder. And many times when they return to homes that were really the cause of their trauma, you know, it reopens that wound. And that's where we have a lot of issues. So it's important for us when we do the reentry plans that we talk about, you know, in conducting those assessments. There are some folks who have units that do assessments. For El Paso, what we do is we have the probation officer who's going to supervise the case to conduct the risks and needs assessment, because that's the best way to get to know the individual that they're going to be responsible for supervising, creating treatment plans, and more importantly, brokering services with local behavioral health communities. The process and collaborations with victim services, law enforcement, courts, and community-based behavioral health and social service agencies is critical. Again, Texas is not a Medicaid expansion state, so any services that we cannot provide, we do have all our clinical services for substance use disorders, and I have some LPCs on staff, but we really heavily rely on the local mental health authority. We really heavily rely on programs that are funded by states, by grants, you know, from TANSA, from other great partners that facilitate the treatment for our clients who are indigent. And many folks, because either their criminal record or their persistent mental illness, do not have jobs that provide insurance. They don't qualify for Social Security because they've moved around. You know, being transient, in order for a person to apply for, that's where the SOAR program is great, but a lot of folks who are transient, it's very difficult to keep up with appointments. So there's been some gaps on that we're still trying to address now. And for example, what's going on right now in the country, that people are being evicted, that's going to be another challenge that we're looking at and we're trying to face, because folks need to tell us where they live. So it's really important to always keep our fingers on the pulse of what's going on, how our community is changing, to make sure that we can adjust and adapt, and more importantly, to make sure that we provide the best service for the clients that are entrusted to us, with the understanding that if we as professionals, you know, with homes and jobs and so forth, are having a difficult time during this COVID time, during this crisis, imagine our clients who are really at the mercy of the services that should be provided at the local level, but have now been transformed or transitioned into a more networking when it comes down to doing any kind of video conferencing and so forth. So it's a really difficult transition for a lot of folks, and that's part of where we talk about being patient. And we understand that when self-care is critical for our staff, and we promote a lot of self-care. We have EAP programs for our staff when they feel overwhelmed, and we, you know, monthly newsletter comes out from our EAP provider. Are you feeling tired? Are you feeling sick? Are things that didn't bother you? We have open appointments. So make it a point to make sure that our staff takes care of themselves, so they're able to provide the level of care and services that are necessary to be effective in working with folks who many times have very high needs. Next slide, please. So establishing the terms and conditions of probation, again, is the terms and condition is the contract, if you will, that a client makes with the court to say, as an alternative to sentencing, I will remain in the community. I will adhere or abide by the terms and conditions that are outlined in this contract. And everything from, it really varies among jurisdictions, but the standard ones in Texas that are identified in the Code of Criminal Procedures is basically, you know, you shall not use alcohol, enter into bars. One of the ones that I have a little bit of a problem with is you will not engage with people of disreputable or harmful character, more specific people who are on community supervision. And that's a problem because, as Dr. Callahan talked about earlier, many times that's the support system. You know, that's the peer support that they have. And we have a lot of recovery coaches who are on community supervision, and they've learned their lesson and they're in recovery. And more importantly, they're willing to share the knowledge that they have with other folks who need that assistance in navigating a system that they may not be familiar with, or simply aren't stable enough to be able to navigate it on their own. So when we do the risk and need and responsivity is identifying the best approach for the individual. Once we conduct the assessment, which usually takes about 2 hours, we collect information. And from there, they are scored on what risk level. And if it's a low risk, then those folks are ones who have probably made a bad decision, ended up in the criminal justice system, we broker some referrals, and studies show that those folks the experience of being incarcerated or going through a criminal justice system alone has taken corrective action. And we link them to workforce development. We link them back to school. We make sure that they have something to step on a foundation to continue to be successful on their own. We try to focus on the 10 and 20% of the population that have very high risk and very high needs. And those are the folks that we actually design very specific treatment plans. Those are the folks that usually end up in our specialized units. Like I said, we have a mental health unit. We have a gender responsive court that we developed a few years ago because, as Dr. Callahan talked about, it's important to make sure that both are protected, not just the men and the women, but the fact of the folks who want to be able to express themselves and feeling safe in doing so. So even the gender responsive court is changing. It's morphing into expanding into different tracks. So again, this is a field that is ever changing. And if any time it's changing more so now. I've been in this field for 25 years now, and I've never seen anything quite like it. You know, we're literally having to change the script on how we do community supervision. But we're very fortunate that we have a judiciary who's very strong in their beliefs and will let me know when they're not happy with me, but more importantly, are willing to listen. And that's the part that's important, that we have, if we can have champions at that level, then they, with their position, can bring other stakeholders to the table. The district attorney's office. You know, I saw a lot of jail coordinators. I saw a lot of coordinators in there who are transitioning folks from the sheriff's department, from the jail, back out into the community. So having the partners within the probation departments or the parole department or simply the local mental health authorities is critical in the warm handoffs and making sure that the goals that have been set or the progress that has been made in the programming, whether it be in the jail or in the transition plan, continue, and that it's not disjointed. And for a lot of individuals, it's important, you know, the continuity of care and that the treatment plan be not so much fluid, but continuous to make sure that it adapts from having everything that they needed in a treatment plan, whether it be a residential center, to now having to navigate a housing community for people who are living in a group center, or simply how do I apply for housing? So all of that is part of case management services that we provide, and our probation officers are trained in doing that now. Monitor compliance, I really don't like to use the word monitor because it seems very distant, But the truth is, what I tell our staff is it's important that we always be informed and we have good cultivating relationships with the clients that we serve. You know, and you hear me say clients and you hear me say justice involved individuals, is just treating people with dignity and respect. And that goes a long way. It goes a long way than to just attaching a term that identifies an offender, a defendant, and so forth. I think it humanizes individuals when we talk to them and we refer to them either by their name or whatever choice they have for us to talk to them. Next slide, please. So something else that we incorporated was the National Institute of Corrections evidence-based practices for effective supervision. So I kind of broke it down here. There's 8 steps and how we do it in El Paso. And the first one is, again, assess risk and need. And we use a Texas risk assessment that was validated and normed, and it was based on the Ohio risk assessment. And let me tell you, when I first came on board, they were in the final stages of implementing. And then I came in and I said, wait a minute, I'm a new chief now, and this is not going to work for our staff. So they had to go back and restructure it. And they actually did a pilot test here in El Paso. And because of our community, we're very different than the rest of Texas. And even our time zone, we're the only city or county in Texas that is in mountain time. Everybody else is central time. So it's important to know that, you know, we wanted to be counted, and we wanted to make sure that at the state level that they understood that the needs are different for individuals based on where they live. Enhance intrinsic motivation. One of the things that we did is we've also partnered with local universities, you know, and that's something that I like to promote and say, you know, there's always grad students looking to do a project and so forth, collect data, and partnering with them was important because they help us see where we are missing, what has worked, what hasn't worked. We help them, they help us, you know, motivational interviewing. We partnered with the University of Texas at El Paso to make sure that there was fidelity to the Texas risk assessment. Like anything else, when we do things over and over again, we sometimes adopt shortcuts, and fidelity is critical so we don't miss anything. Remember, going back to being trauma informed, we can't expect a person who has experienced serious trauma to trust a person that they just met. So talking about when is the best time, how do we address questions that could be unsettling, you know, and even having conversations to say, you know, I'm going to ask you the next couple of questions, maybe a little personal, but I need you to understand that I need to ask those questions in order for this assessment to be useful for us. If you have any difficulty, you can ask me for time. So it's just a matter of, again, treating people with dignity and respect. You know, we have the Treatment Alternatives to Incarceration program, which are monies that were that are designated by our governing body at the state level for treatment for substance use disorders. That money we use internally, and all of our counselors, in order for us to make sure that we provide the same quality of service through the continuum of care, whether it be in a residential facility. I have a residential facility with 120 individuals, all the way to outpatient. And they're all trained on seeking safety, which is evidence-based practice. We also use, for criminogenic needs, we use different curriculums that address and target the specific need. We use MRT for the higher risk folks. Targeting the interventions, you know, when we find constructive ways of motivating people, now we're going to target those interventions and to help people identify the best way of promoting the behavioral change. And it goes back to, again, making sure that our staff understands that the key lies within us on how we execute our supervision plan. And what I mean by that is when we make folks part of the supervision plan, they can tell us, yes, that's doable all at once, or, you know, I think we need to break this down because I feel overwhelmed when I have too much responsibility. So it's important having that communication and that rapport to make sure that we don't overwhelm people, that we don't hand somebody a piece of paper and say, you have to do all this and you have 2 years to do it, so figure it out. What true case management is, what true service coordination is. So we had to go to those levels. So trauma-informed care was the beginning. It was getting people to understand that in order to be an effective community supervision officer that we're called in Texas, we had to be trauma informed. We had to be sensitive to a person's upbringing, culture, way of language, whatever it is that was going to make our relationship effective. And more importantly, a relationship that was going to lead to success of the clients that we serve. You know, we've talked about the risk principle, we talked about the needs principle, but like Dr. Callahan said earlier, you know, we prioritize the supervision for treatment resources for the higher risk folks. And usually folks who have co-occurring disorders and who have been in and out of the justice system have higher levels of need, and they have more challenges and barriers in accessing whether it be care or employment. You know, so it's really focusing on what we can do to continue once they're off probation. You know, Dr. Callahan talks about, you know, reentry starts the day that the person is booked. For us, the transition of terminating a person's probation and successfully discharging them should begin, and it does, the day that we start, because we want them to be successful, not just through the time that they're on community supervision, but that they don't return back on any kind of criminal justice case management services or arrest, because we didn't effectively provide the services that they needed to continue in that path to recovery. The responsivity, again, being responsive to temperament, learning style, motivation, and gender when assessing programs. We've had individuals in the past that everybody had to go to this program if they were part of this caseload. We took, all of that went out the window. We tailor the treatment needs, we tailor the services that are important and necessary for that client. We also take into consideration, is this something that this person needs to do? I'll give you an example. We had a 57-year-old retired individual who had some cognitive problems, and the officer at one point years ago wouldn't release him because he needed to get his GED. You know, it somehow came to my attention by one of the judges. So that was something I said, okay, this is something that we have discretion. So we teach our officers, we empower them to make decisions and say, does the 67-year-old individual really need a GED to be discharged? No, because it's not going to be something that they need moving forward. So having them be critical thinking individuals, and it's something else that we do, is teaching them a different way to see the world, using a more culturally competent lens, and also considering, like I said, the trauma-informed care part of it, that what people need is a respect. They need information. This is why this referral is important. If you don't show up at 10 with these documents, then they're not going to serve you. And the next appointment is not for 6 months. You know, that's why it's important to take time and cultivate relationships. Next slide, please. So number 4 is skill trained with directed practice. Use cognitive behavioral treatment. You know, the objective of community supervision is to re-socialize the individual. That's how I can capture it. You know, re-socialize the individual to change their faulty thinking that led them to becoming justice involved. And for those who have serious and persistent behavioral health conditions, link them with services that are going to help an individual make better decisions and hopefully change the landscape in which they are existing, to make sure that they reduces the incidence of not coming into contact with law enforcement. Increase positive reinforcement and consequences applied. You know, that's important because we have to do it at the level of the individual. What is going to increase somebody's likelihood of continuing and engaging in that positive behavior? Thank you for showing up today. You know, believe you me, I got a lot of pushback in the beginning because, you know, I allow officers, I give them the freedom of speaking their mind and sharing with me what works, what they think they're going to work or what's not. And I had several say, you know, I'm not a social worker, I'm a probation officer. And I said, well, you know, those two terms go hand in hand, because in order for us to be effective, when somebody goes to prison, that's a negative mark on us. So in order for us to facilitate success, yeah, we are social workers. We coordinate care. We're therapists when somebody needs to be listened to, and then make referrals. I said, so it's really maybe taking a look at, is this the right place for me? Because we're going to serve everybody that the courts assign to us. So we're not going to not accept folks into our programs because their needs are too high. Once they're ours, then we have to figure out a way to broker the services that are going to make sure that the services are effective. And even if it's, thank you very much for showing up today, you know, sometimes just words, something that doesn't cost money, it doesn't cost much effort, is just treating people with dignity and respect. Engaging in ongoing and supporting natural communities, that's important. And starting from the beginning, you know, we have people, especially with specialty courts. Dr. Callahan talked about specialized units, and you know, one of those are specialty courts. We have numerous specialty courts, and many individuals who participate in those programs are very successful, but sometimes return to the justice system because they don't know how the reentry plan wasn't effective in them not having somebody clap for them, or somebody reinforce their positive behavior, or somebody compliment them on a job well done. You know, so what we started doing is linking them to service organizations, to volunteerism, to something that helped them find a place in the community where they were welcome and they felt that they belonged and were a part of a greater good. Right now, with what's going on, we've suspended community service because I don't want to risk having somebody being in a place without social distancing, but we have encouraged learning new trades, new skills, that when we do reopen, they can provide, you know, any services to our community. You know, volunteering, walking pets for the elderly. We've had folks that have volunteered with Adult Protective Services by cleaning out houses for elderly who can't live in their homes because they have hoarding. So partnering with local partners and law enforcement has also changed the perspective of the individuals and how they see law enforcement. You know, we partner with the Sheriff's Department because the Sheriff's Department has a great outreach initiative in community services. So we've had clients who are on probation who are electricians to help the Sheriff's Department, you know, rewire a house for a widow whose husband died by being electrocuted when he was doing that. So there's a lot of initiatives that we created, and most of it is having people feel good about themselves, giving them purpose, measuring relevant processes and practices, outcome measures. We instituted different ways of how do we know it's working. You know, when I was teaching in the past, you know, it was the CAT system, you know, how do we know that what we're teaching, they're learning? And this is where we do retrospective reviews. We talk about roundtables and what we can do better. We listen to the field to find out what it is that we need to do to continue to succeed. You know, provide feedback, quality assurance, and performance audits. That's also something too. You know, making sure that we have professional development ongoing, especially now, to make sure that we understand what's out there. We understand, because again, there is nothing that we can use as a historical perspective on this is how we respond to this kind of pandemic. We don't know what to expect when we open the doors 100%. You know, we have people who are afraid for their safety. We have officers who are afraid of you know, having contact with somebody who's been exposed and their children and so forth. So we provide a lot of professional development for that, and say now when we meet with our clients, whether it be virtually or over the phone, we ask them, how are you doing? So as a chief, you know, I like to see what work we can do. And occasionally I'll pick up somebody's list and I'll go do home visits during this time. And let me tell you, we have individuals who are very responsive and happy to see us. And I said, we just want to make sure that you were okay. We understand that, you know, we haven't been able to talk to you because you don't have a phone. And, oh no, thank you for coming. Especially those folks who have really severed ties with their loved ones. And usually, you know, through fault of their own, you know, due to substance use disorders, due to, you know, them going in and out of jail, or simply untreated mental health conditions. Next slide, please. So basically, in a nutshell, this is what the best practice is for community supervision. You know, we assess the individual using the TRAS, we identify the level of need, we identify the risks that are involved, and we target the interventions, whether it be within the department or whether it be the community-based partners. You know, we design the supervision plan with the person being a part of it, the treatment plan. We work, our officers work with our counselors to make sure that we have an integrated plan and not two disjointed plans. We want to facilitate success for our clients, so we want to make sure that continuity of care is always present. Whether they're going to go into another program, whether they're moving to another city, or simply they're transitioning into what we call the low-risk caseload, where we'll see them every other month. It's like transitioning them out. That's part of the incentives, is to say, if you can do this for this amount of time, then we'll start transitioning you into what's called a low-risk caseload. You don't have to come, you don't have to take the bus, you don't have to, we'll reach out to you, and we'll do mobile units for that. The cross-system collaboration between community providers and criminal justice professionals is essential for ensuring this continuity of care, because we can't do it on our own. But once we link individuals to services that are out in the community, they can continue to access them even when they're no longer involved with the justice system. And it supports both correctional settings and in the community. And these little arrows is something that I designed that says, you know, we have to work together. We have to make sure that we both understand, and we provided training. I've done trauma-informed care for local not-for-profit organizations that share clients, that we have mutual clients for. Just so they understand, we partner with the YWCA to provide GED classes, and I did trauma-informed care for them too. This is the population you're going to be working with. You know, so if they're going to have access, or if they're going to provide services or programs for the clients that we serve, then for me, it's important that they understand universal assumptions of trauma. Next slide, please. So I believe that this is where I pass it back to Dr. Callahan.
Okay, thank you, Maggie, and I look forward to everyone's questions and picking Maggie's brain about all the great work that she's done in El Paso. So now that we've talked about Intercepts 0 through 5, just wanted to review some of the really the universal best practices across all 6 intercepts. I always forget to count 0, and I think it ends in 5, but it's 0 through 5. And that's the R&R model, as I talked about and Maggie talked about. That applies across all the intercepts, making sure that you are taking into account substance use, because that is, even if you're dealing with a justice-involved population that you believe is primarily suffering from mental illness, chances are they have a co-occurring disorder. The really important role of peers and the value that peers can bring to your programs, especially when you're working with justice-involved folks who have mental illness and substance use disorders. This is, Maggie alluded to this, and sometimes this is a challenge in some parts, some agencies within the criminal justice system, because you want to engage peers that really have been where your clients are, where your probationers are, where your mental health participants are. And usually that includes having a justice history. And some agencies are unwilling to allow people with a justice history to be officially be part of a team. So that's something that, again, you can lean on your judges to talk with the head of probation to explain the importance of that. There's a legitimacy with peers who can speak really very, very close to the heart and close to the bone of what people are going through and how hard it is to be successful on probation, how hard it is to be successful in a treatment court, because it is hard. There's a lot of expectations. And so the role of peers, and in many of the programs that I still am in touch with, right now, peers are among the only part of the treatment team that are actually still going out and doing home visits. They feel very strongly, and they know generally where they can find people too, if their housing perhaps isn't as predictable as it was before COVID. So if peers aren't integrated into your programs, I would strongly encourage you to bring them in. They're different than mentors, and that's a term that's used in some treatment courts, especially in veterans treatment courts. Peers are people with lived experience, with the lived experience of the clients that you're asking them to work with. And the housing continuum, it's a huge issue, and one that in my next life, I'm going to come back and solve the housing problem for the world, for the United States. That's my dream of dreams. Next slide, please. When you do a sequential intercept mapping, one of the findings that's often revealed is that some of the gaps that you think are only yours actually are gaps across all of the intercepts, or at least some of the intercepts share the same gaps. And a number of them are listed here. These aren't, certainly, this is not an exhaustive list. And this doesn't necessarily mean that your community has all of these. But, you know, without taking too deep of a dive into these, we've been talking all along about making sure that you have that your planning process is really coordinated across all of the intercepts that are specifically related to the success of the people you are either treating or are supervising. Bullet number 2, information sharing. That's a real bug in a lot of communities. Often the behavioral health providers will say they can't share data with the criminal justice providers because of HIPAA. That's like the big thing you hide behind is HIPAA. Some states have specific language that allows criminal justice and mental health or behavioral health to share, but this is something I promise you can solve this problem. So if this is something that's an issue in your community, reach out to me. We've been working a lot on this year and last year in terms of working with communities to be able to share data, coming up with memoranda of understanding and data sharing agreements. It can be done. It can be done despite what the lawyers for your agency are going to say. Cross-training, using evidence-based practices, being trauma-informed. And when we talk about being trauma-informed, everyone in your agency should be trauma-informed, from the person who picks up the phone and answers the phone, or the person who is supervising the front desk, to the security person who's letting people in. They all need to be trauma-informed. That's the first impression, right? Is the person who picks up the phone and the person who's at the front door. So they may not be the provider, but they're the face of your organization for someone coming in the front door. So please keep that in mind when you are implementing trauma-informed practices. It's not just the direct care people, but it's the people who are your transportation people, the people who drive people back and forth between jail and court need to be trauma-informed. Really important. Making sure that you have screening for military service. And there are ways to ask this and ways not to ask this to elicit the information that you want. There are a lot of reasons for this, not the least of which is some of the people in your program or probationers or people on parole, if they are part of the US military, there are programs and services that may be available to them that are more suitable to their military service than what you can provide. I would say it's also could be a financial incentive. If the VA pays for treatment, then that's a good thing. At the very least, they probably will pay for their medications. Making sure that you integrate healthcare, again, peer services, housing, I've mentioned that a lot. And another area that we've been focusing a lot on at the Gain Center this year is data and what kind of data you need to collect to make sure that your program has integrity and that you have the right resources at the right points across the SIM. Maggie mentioned that in terms of if you have a community college or a university or college in your nearby, great partners to have, and usually it's free, which is a good thing. Next slide, please. We've mentioned a couple of times specialized caseloads, and I think we've touched on it enough to not have to go into too much detail here, but this is something, if you don't have specialized caseloads within your probation department, I would put that at the top of your list of ways in which to become, it's hand in hand with becoming trauma informed. Just a quick anecdote. Years ago when I was still teaching, when I was a college professor, one of my students was doing her internship as a senior at a local probation department, adult probation department. And she had taken a couple of my courses. I taught one on criminal justice and mental health. And she went to the head of probation when she was interviewing and setting up her internship. She said, I'd like to work with the probation officer who handles the mental health caseload. And the response to her was, we don't have anyone with mental illness on probation. So that was the baseline. And I would say and that we're much further ahead. That was probably 20 years ago that was her response. So while there may not be specialized caseloads, there certainly are probation officers such as Maggie when she was not the chief, but when she was one of the probation officers who have more than a working knowledge of behavioral health and treatment because she's a licensed therapist as well. Next slide, please. Okay, just to summarize, and this is specifically for 4.5, but it really extends over the entire SIM, is using this model to leverage your community brain trust. Maggie talked about bringing everyone to the table. She really did make the judges sign in to her meetings about becoming trauma informed. People assume this universal assumption about trauma. People with behavioral health histories have trauma histories. And it's just assumed that there's no cost involved whatsoever in making that assumption, and that being your lead is that the person that you're going to be working with, that you're planning their treatment plan or their supervision plan, that they have a trauma history. People with trauma histories use a lot of healthcare. They go to the emergency departments a lot. So the extent to which you can address their trauma histories in the course of their care and treatment and supervision, the more you're going to help relieve really the pressure on the emergency departments and the EMS services in your community. So they can be a real ally for you. They can be a very strong stakeholder for you, because if you can address the trauma, you are going to reduce their heavy reliance on the emergency departments. People with trauma histories die earlier. Many cases, they die as the result of violence, as being the victim of crime. They die earlier from disease. They also run the risk of just deeper exposure to the criminal justice system, just being pushed deeper and deeper into the criminal justice system. And that's never a good place for someone who has a significant trauma history. You want to make sure that there are seamless transitions back and forth across the system. And that is all the way across the SIM, but also within the systems that work, that are your partners, your stakeholders, and make sure that you have a strategic plan, that you sit down with your stakeholders and start with the assumption that being trauma informed improves public safety. It certainly improves public health outcomes, but it also improves public safety. And then develop a plan of how you're going to implement trauma-informed practices across all the intercepts. Next slide, and I think I'm passing this off now to Ethan.
Yes, thank you, Dr. Callahan. Thank you, Maggie, for that presentation. So I'm going to turn it over to the discussion portion of the learning community. Allison, next slide, please. And so we did want to do a polling question. And so the question is, do your probation and parole agencies utilize special caseloads, as Lisa and Maggie were just talking about? Okay, so looks like the results, so it looks like about half have mental health special caseloads, about 20% have youth, 11% other. I'd be curious to hear what the other are, and about half of you have, almost half are unknown, so it's an interesting mix. So certainly something to think about, as you've heard in the presentation today. Next slide, please. And so I did want to turn it back over, certainly to the grantees, and if you had any questions for Maggie, based on her presentation, the things that are some of the initiatives that she's talked about in El Paso County. And I'd actually like to start it off. Something that had come up for me when you were talking, Maggie, was about state level, what things that are happening at the state level. And so are there initiatives currently happening at the state level for trauma-informed care in Texas?
Definitely. I also belong to the Probation Advisory Council, which is a state level committee that comprises of directors from across the state. And this is something that we're talking about. And the presentation that I did today, I did a form of it at the state level to talk about why is it that, talking about data, Dr. Callahan was talking about data, you know, there's a lot of data collection that suggests that we had revocations, like I said, related to more a violation of a technical than reoffenses. So in understanding, we started doing more training on trauma-informed care. We've done trauma-informed care trainings at the state level agencies like the Texas Probation Association and so forth, and just promoting understanding about trauma-informed care. At the legislative level, I'm the urban chief that represents the Probation Advisory Committee. And that's something that I'm bringing to the table. That's something that we're sharing the knowledge and really pushing. There was a legislation this last session that was asking, it didn't pass because of the way it was worded, but asking for trauma-informed care therapists to be employed. The only reason it didn't pass it because it was going to be an unfunded mandate. So instead, you know, what we're doing is promoting more trauma-informed care within the state, within our agencies, to make sure that we can identify, refer, and more importantly, be more mindful of how using the universal assumptions of trauma minimizes re-traumatizing individuals.
Thank you. I'll now turn it over to the group. Do others have questions for Maggie? Anywhere from sort of what's going on in El Paso, other types on specialized caseloads?
I have a question for you, Maggie.
Yes.
Out of curiosity, since you are the chief of probation, when you're hiring future probation and parole officers, are you asking them specifically if they have either a specialty or let's say, you know, a probation officer is particularly interested in dealing with probationers that have gang ties or, you know, have a gang history? Are you putting that, I mean, are you asking them what their specialty is, or are you just hiring probation officers and saying, hey, choose something that you're interested in and we'll provide you the training to best serve those probationers?
And the way it works is that I don't do the direct hiring. We have panels that do that, and we do screening. And part of the application process is share with us what your skill set is. Share with us your experience. But one of I know that a question has to be asked in the beginning is, do you believe people can change? You know, what are your thoughts about, why do you want to work for a probation department? And we're really looking for folks who say, I want to make a difference, or I'm not too familiar with it, but I have a background in psychology and I want to learn about how I can do better, how I can contribute to making change and becoming an agent of change. And if the person isn't fortunate enough to have had the experience, we have plenty of professional development if they show interest in doing that. So yes, we do ask, and there's a part of the application process that gives them an opportunity to share with us what their preferences would be. And more importantly, you know, if they choose to learn a certain, working with, like you talked about gangs. I love working with gangs because that was my upbringing. So identifying what somebody's passionate about is, I think, the key to recruitment.
All right, thank you, I appreciate it.
Meg, I did have another question for you. And if you're, things you're comfortable elaborating on about some of the challenges that you indicated you had on an organizational level when trying to bring trauma-informed care to El Paso and the probation department.
And this is kind of going toward, I think, the direction that Lee was asking about, Ms. Culver. And it is that some people's misperception of what the role of a probation officer is, or a community supervision officer. They believe that we're an extension of law enforcement, when in reality, we're agents of change. We're brokers of services. And we have to understand the role changes that have occurred, from, like I said, the tail 'em, jail 'em, and nail 'em, to actually becoming that agent of change to help people change the direction of their life, to facilitate their success through identifying, sometimes folks know what they need or know where they want to be, they just don't know how to access it. So part of what we do is identify, again, the risk and needs, and making sure that we can direct them, refer them, and if we don't have those referrals, develop a sense or a program that we can do by providing those services. So I don't know if I've answered your question, but it's really important for us to know that there's a lot of people who at one point learned that the department was taking a different direction, that we weren't here, that in order for us to effectuate change, in order for us to reduce recidivism, in order for us to improve our outcomes, we had to change the way not only we saw ourselves, but the populations that we served. So our lens had to change. And that's part of the professional development. So the conversation really began with when I started doing the trauma-informed care. And again, I think it started with having, because I'm the director, I had a disclaimer in the beginning that said, right now, I'm not your director. Right now, I'm the trauma trainer. And in order for us to change perspectives, to change ideas, or simply positions and biases, we have to be honest with what we see. So we had very candid conversations. We had people who sometimes broke down and were very candid about what they had to say, and it was emotionally charged, and a lot of it had to do with their own unresolved traumas. So it was really, like I said, it was very powerful, but at the same time, there were people who said, this is not for me, this is not the role that I want to play. So they left the department by their own choice, and they looked for other directions, and many of them, years later or whatever, sent emails and say, I want to thank you for giving me that opportunity to learn about that wasn't really for me. I'm now teaching, or I went back to grad school, or I did whatever, and I truly found my niche. I find myself working with populations that I want to work with, or I totally changed it and went to become a nurse. And I'm more passionate now about behavioral health because I work for the local mental health authority. So it's really about, I think, self-discovery, and sometimes, changing the narrative, but giving people permission to do so. And sometimes, when people come into the workforce thinking, I have to be hard, you can't, that's what we learned back in the day in college about corrections. You don't disclose yourself, you can't be human, you have to be almost robotic. That's not who we are. So just kind of what this profession has morphed into. And a lot of it begins with the professional development. And for me, it was really about the trauma-informed care.
Well, thank you. That's helpful. I think the perception of parole and probation officers and how they see their roles, I think that's really important. And I think just to put out to the rest of the group, and whether people have some thoughts now on this, but just in terms of grant teams thinking about their own organizational culture, and sometimes how organizational cultures get set in certain ways, and with trauma-informed care is going to sort of be sort of counter to that in some way, or sort of not totally in touch with that, and sort of what things you might run into as you're trying to move forward with trauma-informed practices. So,
the climate of today, that's really what it's rooted in, right? It's about treating just as involved individuals with dignity and respect. So it's everywhere, and I think it's something that we have to sometimes look at ourselves and identify our own implicit or explicit biases.
Maggie, we have something for a question from the chat box. So are there any strategies you have put in place with your staff related to racial injustice and social disparities as it applies to clients?
Yes, and a lot of it is, it really, again, we are predominantly, you know, a Hispanic, usually Mexican American, but as I indicated earlier, we are having, after the base realignment closure, work list expanded. So we have people from all over the country coming in, and we can never make assumptions. And that's the number one rule when it comes to cultural competence. If you want to know something about the client, then it's important that we do that during the initial stages, you know, of our interview process. Is what is this like? That's how, you know, we can't make assumptions. We can't put all people in a box. So in order, like like Dr. Callahan said, I'm a trained therapist. So we don't develop treatment plans based on somebody's race and so forth like that. So in order for us to be effective in our role, we have to understand that we're working with individuals and treating people with dignity and respect, collecting information that is important in developing those treatment plans, those supervision plans. But as far as awareness, yes, we're like I said, we're advocates and we are inclusive. And I'm not only doing that at the El Paso level, at the state level in the communities that I'm at, you know, I am always raising the issue of equity and inclusion. You know, I do trainings on equity and inclusion because it's important for people to understand. Sometimes I think, and for lack of a better word, is ignorance of what that means. So educating individuals on what it means, and again, having to look at ourselves, it's important that we institute that lens for individuals and for our staff to be able to, the rule of thumb is treat everybody with dignity and respect, and find out from them, you know, not just based on their looks, but based on what they're bringing to the table. And it's just conducting assessments of the individual.
Thank you, Maggie. Allison, did you have a question?
Oh, sure. Yes, I just, first of all, it was such an interesting topic today, and just thanks to all of our presenters and all the attendees. My question was, you know, for Maggie and Lisa as well too, of course, just curious about your thoughts on specialized caseloads for women that you're working with, and if you have experience with that, whether you found it effective. And I'm just thinking about, I don't have the exact data right at my fingertips, but from studies that I've read about the number of women, of course, fastest rising population in the justice system today, right, over recent years, but also percentage-wise, but also that a large percentage of the women in custody are there because of revocations, right? So I should say in correctional facilities are there for revocations. So wondering if you think that a specialized caseload could assist with that, or just any of your thoughts on working with women in general.
Maggie, I think you're more qualified to answer that than I.
Dr. Callahan, I learned from the best. So what we're doing now, and even that, you know, what I talked about earlier, is not all women have the same needs. So we have to be able to assess individuals. We have gender responsive programming. All are females, and how we do it is gender responsive is, in this case, is a gender based. So we have to make sure that we provide the level of care for when it comes to women who identify as women, you know, be with a female therapist and so forth. That's where we go. But beyond that, we don't create programming just based on the female, because we have the LGBTQ plus community. So it's really important for our therapists to understand that to design plans for individuals, we have to design it based on the needs that they're bringing to the table. I'll give you an example. We have programming. Sometimes there's monies available that we can apply for, but the criteria is that they have to have women have to have children to be eligible. Well, you know, there goes my response and saying not all women have children. You know, so making sure parenting classes. Well, your assumption is that all women are parents. So I think a lot of it is to dispel a lot of the misconceptions of what gender responsive programming is. It's not all just about parenting. It's not all just about, but really identifying at the core what issues lie within that person and why they've been just as involved or why they became just as involved and what was missing or what we can do to facilitate, you know, their recovery or their success. So it's really about understanding individuals. And we do that at the clinical assessment program. But in general, you know, gender responsive programming, we have a general program description, but the treatment plans are designed individually in accordance with either the clinical assessment or the Texas risk assessment to identify the needs for the particular individual.
Thank you.
So any other questions for Maggie, or also I wanted to turn it over to the group if anybody has anything they'd like to share and sort of takeaways from the learning community. Certainly open to hear any kind of updates on any sort of initiatives people are trying. We'll open it up to the group.
Hi, this is Charity from Chatham County. I just want to say thank you for this. It really was eye-opening for me when it comes to probation. We really have not gotten that far down our sequential map. We're still kind of at the beginning stages. So for me, it's been very eye-opening. And yeah, I had a lot of thoughts of, you know, probation officers kind of like an extension of policing after. So this has been fabulous for me. So thank you. And I can't wait till we start getting towards that part of our map to be able to have so much more knowledge now. So thank you.
Thank you for sharing. Thoughts from others?
I have a question. This is Lisa, if I could. And I'm wondering if the people who are participating from, you know, from the various grantees, whether they've made a mental list or an actual list, started to think about who their stakeholders, who they think they are their easy partners and who might require a little bit of, I'm not going to say arm twisting, but a little bit more convincing, perhaps. Or who does the judge have to call? I mean, I guess that's the...
I will say that one of our biggest stakeholders is our superior judge for the mental health court, Judge Friesman. And so I think when we do get kind of down that line, when it comes to that time, she's been just such a stakeholder in this. So I think she'll be very helpful for us.
We've done a lot of training with the judges in Georgia. I've actually spoken to your judges conferences a number of times on trauma-informed courts, so I'm glad to hear that.
Yeah, great.
You know, I also want to share that in the non-traditional roles that we have, especially in traditional communities like we have here in El Paso, you know, when working with, like, we partner with the Texas Workforce Commission, where they're looking to recruit women or females or people who identify as female in non-traditional jobs, like training them in vocations like plumbing or diesel mechanics and stuff. And when we brought it to our program, people were excited, you know, and I think it's important to do just that. Is not, now the norm is whatever the person considers to be the norm. And I believe that right now there's really no perfect way of addressing diversity and equity and so forth. But if we start and we root it again with the universal assumptions of trauma, with treating people with dignity and respect, and really asking them what would be an ideal resolution for you, or where would you want to be? I don't have a clue. Well, let's start helping you look at something. You know, I think it's really about person-centered, you know, which is motivational interview. It's person-centered, is working one-on-one with a person and finding out how can we go through this journey, because being a community supervision officer is a journey. You know, being the mental health officer, I practically raised several of my clients because they couldn't go anywhere else. If they were on probation for 10 years, guess what? I had them for 10 years. So I learned a lot. And I also knew that sometimes what I thought I knew didn't apply to everybody. So I think that's the rule of thumb, is to understand people, you have to know the person.
Thank you, Maggie. Just being mindful of our time, Allison, do you want to go to the next slide? So now I'm just going to briefly just touch on sort of our follow-up session and exercise, or the exercise that you all are engaged in now. Next slide, please. So just some things that we've touched on, both Dr. Callahan and Maggie have touched on today, and trying to sort of move this along, you know, in terms of taking it from identifying an area that might need some change and then implementing a practice. And so what we're planning to do for the follow-up session is really to make it that more of a peer learning. We'll certainly facilitate the discussion a little bit, and some of the things to think about between now and then is who will need to be at the table, educating staff and colleagues on trauma-informed care. As Maggie was saying, many people just don't know what it is. And then even thinking about things, trying not to complicate things too much. I know we're talking about a lot of complex issues, but thinking about like what can be done tomorrow to be more trauma-informed care. And Dr. Callahan has, you know, has said it, I think, a few times on this, is something to say they don't cost money. It's really about how the sort of interpersonal approach to some of the work. And so, you know, and then thinking further down the road, what will need more time and planning for sustained change. And so this might be, right, how do you sort of bring other kinds of stakeholders along? What are some, you know, longer term or some policy things that might need to come into place in order to keep practice going? So again, this is sort of how we're going to wrap up the learning community in the fourth session. Will just be a discussion about the implementation. Again, trying to build that peer learning component of this as you all move forward in implementing trauma-informed care. So any final thoughts from the facilitators or grantees, please?
I just want to wish everybody luck in this journey. And I hope that you get to experience and feel the joy that I've felt in seeing our profession grow and change and become a more trauma-informed community to be able to provide the best service that we can for the justice involved individuals that are entrusted to us. And thank you for what you do.
Thank you. All right. Well, that is our time. Thank you, everybody. Stay safe, stay well.
Thank you, everyone.
Thank you, everyone.
Thank you.
Thank you.